Bismillahirrahmanirrahim. On to our last session of the musculoskeletal system. So let's get straight into it. Firstly, we'll see the arachidonic acid pathway. So arachidonic acid pathway looks something like this. Firstly, we'll have membrane phospholipids, which are broken down by the phospholipase A2 into arachidonic acid. The arachidonic acid then can go into 5-lipoxygenase pathway or in the cyclooxygenase pathway. Firstly, we'll talk about lipoxygenase pathway. If the 5-lipoxygenase enzyme is acting on the arachidonic acid, it will cause the formation of 5-HPETE. 5-HPETE will be formed, and if the 5-HPETE is formed, resultantly the leukotrienes are formed like LTB4, C4D4 and E4. LTB4 is responsible for the neutrophilic chemotaxis, and LTC4, D4 and E4 are also called the slow reacting substances of anaphylaxis, and they will increase the bronchial tone, right? Then we'll talk about arachidonic acid if it is going to the cyclooxygenase pathway. In the cyclooxygenase pathway, we have two enzymes, COX-1 and COX-2. I guess they both of them produce similar products. The difference is between the the drugs that target them. So the COX-1 and COX-2, they will produce cyclic endoperoxides, which will lead to the formation of these three compounds: prostacyclins, prostaglandins, and the thromboxanes. So prostacyclins are PGI2. They will decrease the platelet aggregation and decrease the vascular tone, and they are seen with the epoprostenol. Okay, so they are seen epoprostenol, prostaglandins PGE1, E2 and PGF2 alpha. So decrease the vascular tone, PGE2 increase the uterine tone, and PGF2 alpha increases the uterine tone. Alprostadil, okay, forget about the drugs right now. PGI2, PGE1, E2 and F2 alpha, and thromboxane A2 that increases the platelet aggregation and increases the vascular tone. So you can see the thromboxane A2 and PGI2, the thromboxanes and the prostacyclins, they are arch enemies of each other. The prostacyclin decreases the platelet aggregation, thromboxane increases that. The prostacyclins decrease the vascular tone while the thromboxane increase that. So remember the difference. Now let's talk about the drugs. So firstly we'll go to the leukotriene pathway, the lipoxygenase pathway, then we'll come to the cyclooxygenase pathway. But before both of them, let's see the common pathway. The membrane phospholipids are broken down into arachidonic acid by phospholipase A2. The glucocorticoids, which are anti-inflammatory agents, they will inhibit this pathway. Okay, so they will directly inhibit the phospholipase A2 and will not allow the formation of arachidonic acid in first place. Now let's leave it till here, and then we'll continue from here onward in the COX pathway. In the LOX pathway, arachidonic acid is converted into 5-HPETE. That 5-lipoxygenase. The 5-lipoxygenase enzyme is inhibited by the xylutone. Okay, so that is the 5-lipoxygenase inhibitor. Then the 5-HPET is formed that forms the leukotrienes. Now the montelukast and zafirlukast, they are going to inhibit the LTC4, D4 and E4 because both of them are receptor inhibitors of these drugs. These agents, LTC4, D4 and E4, they cannot bind to the receptors because of these drugs. So these are leukotriene receptor antagonist, montelukast and zafirlukast. Okay, we are done with the LOX pathway. Now coming to a more complicated COX pathway. So in the COX pathway, the glucocorticoids or corticosteroids, they stimulate the IKB. IKB will inhibit the inhibitor of the kappa B. IKB will inhibit the NF kappa B. Now normally NF kappa B is responsible for the synthesis of COX-2, but if the IKB is inhibiting the NF kappa B, resultantly the COX-2 will not be formed and there will be down regulation of the COX pathway. First thing. Secondly, if we use endoperoxide synthesis, that is cyclooxygenase, so the celecoxib is specific inhibitor of the COX-2 only, while for the non-specific inhibition of COX-1 and COX-2 we can use aspirin, that is irreversible inhibitor. Other NSAIDs which are reversible inhibitors include diclofenac, ketorolac, naproxen, ibuprofen and indomethacin. The thing that you must remember is aspirin is an irreversible inhibitor of the COX-1 and 2 both, while other NSAIDs, diclofenac, ketorolac, ibuprofen, naproxen and indomethacin, they are reversible inhibitors. Then we have like LTB4 is a neutrophil chemotactic agent. Prostacyclin PGI2 inhibit the platelet aggregation and promote the vasodilation. Neutrophil arrive before others, so that is the LTB4, that is the chemotactic for the neutrophil, that's a good mnemonic. And platelet gathering inhibitor or PGI. What? Platelet gathering inhibitor, PGI. So platelet gathering, PGI does not allow the aggregation of the platelet, so that is why it is the platelet gathering inhibitor. Remember it like that. And then the opposite of that is thromboxane. So that will become much easier for you in that way. Again, we have cyclooxygenase inhibitor, arachidonic acid. Now we are talking about COX-1 and COX-2 individually. COX-1 is inhibited by the aspirin and NSAIDs. Aspirin NSAID can also inhibit the COX-2, but COX-2 specific inhibitor, for example, celecoxib, they will inhibit only the COX-2. So COX-1 has constitutive prostaglandins which are expressed all the times, right? They perform the physiologic function like gastric mucosal protection, increase the renal perfusion, they modulate the platelet aggregation, you may say that. But the COX-2 will produce the inducible prostaglandins, which are induced or produced due to as a result of exposure to some cytokines only. They will not be produced constitutively in the normal physiologic state. They are not present. For example, in the physiologic function, for example, to increase the renal perfusion, to cause vasodilation, tissue repair in response to cytokines or in response to stimuli, they are being produced. And via COX-2 pathway in pathologic function like increased pain sensitivity and in the inflammation, these cytokines, these prostaglandins are produced. While the COX-2 will produce prostaglandins only when it is given signals, while the COX-1 is expressed constitutively and it will be expressing these prostaglandins constitutive expression of that will be there. Now let's talk about inflammatory mediators. Phospholipase A2 function, it converts the membrane phospholipids to the arachidonic acid, and it is inhibited by the glucocorticoids phospholipase A2. As we saw here, the phospholipase A2 is inhibited by the glucocorticoids. Coming back to the table, 5-lipoxygenase enzyme of the LOX pathway, it converts the arachidonic acid to 5-HPETE. The diluent is a direct inhibitor of the 5-lipoxygenase. The COX-1 converts the arachidonic acid to cyclic endoperoxides. It is inhibited by the aspirin, other NSAIDs besides celecoxib. So it is inhibited by the aspirin and other NSAIDs besides celecoxib. The COX-2, it converts the arachidonic acid to cyclic endoperoxides except in the gut. That is also inhibited by the celecoxib. Leukotriene LDC4, D4 and E4, they maintain the bronchial tone and they inhibit the montelukast. They are inhibited by the montelukast and zafirlukast, which are the receptor antagonist of LTC4, B4 and D4. As you can see over here, zafirlukast and montelukast, these are the receptor antagonists of these drugs. Then coming back to the so LTB4, neutrophilic chemotaxis. Okay, so there is no drug that is inhibiting this one because we don't need to inhibit that. That is in our favor. We need neutrophilic chemotaxis for the infections. So neutrophilic chemotaxis, neutrophils arrive before others. Prostacyclin, PGI2, platelet aggregation and vascular tone is that is going to inhibit or decrease. That is going to decrease the platelet aggregation and vascular tone. Platelet gathering inhibitor. It is favored by epoprostenol. PGE1 is going to increase the vascular tone. PGE1, that decreases the vascular tone. Okay. PGE1 will give me a second. Yeah, PGE1 will decrease the vascular tone, and the positive drug for that is L-prostadil. The prostaglandin E2, that increases the uterine tone, and the dinoprostone is the agonist of that. If we need to increase the uterine tone, maybe during the pregnancy, prostaglandins PGE2 alpha, they also increase the uterine tone, and we give caboprost for that. I guess they increase the uterine tone, right? Here you can see that both the PGE2 and PGF2 alpha, they are increasing the uterine tone, and it must be PGF2 alpha. Okay, PGF2 alpha. Okay, then thromboxane A2, platelet aggregation and vascular tone, and this is not agonized by any drug. Moving forward to this table, we have seen this table, but it is a Uworld version of that table. So membrane phospholipids are broken down into arachidonic acid by the phospholipase A2. Now it can either go to the LOX pathway by 5-lipoxygenase or COX pathway by cyclooxygenase 1 and 2. We'll see the LOX pathway first. The lipoxygenase 5-lipoxygenase will convert the arachidonic acid into 5-HPETE. On that, 12-lipoxygenase will act, and 12-lipoxygenase will form LTA4 and B4. B4 is for the leukocyte recruitment. Both of these LTA4 and B4 are anti-inflammatory. Okay, and 5-HETE, I'm sorry. What's that? Why is LTB4 there? LTB4. I'm sorry, these are not leukotrienes. I'm very sorry. These are lipoxin A4 and lipoxin B4. Okay, so these are lipoxins. They are not like leukotrienes. They are lipoxins. So lipoxin A4 and B4 are anti-inflammatory because they will decrease the leukocyte recruitment. Okay, I guess both of them will decrease the leukocyte recruitment, and they are anti-inflammatory components of the LOX pathway. These are lipoxins. Okay, lipoxins have an X, so they will decrease the inflammation. Lipoxins. Okay, then 5-HETE, leukotriene B4, that favors the chemotaxis, that is pro-inflammatory. Then LTC4, D4 and E4, that causes vasoconstriction, increased vascular permeability, bronchospasm, that is also pro-inflammatory. Talking about COX pathway, So COX-1 and COX-2, COX-1 constitutively, COX-2 under some particular conditions, on receiving some stimuli, you may say that will produce a prostaglandin H2. Prostaglandin H2 is then broken down into thromboxanes, prostacyclins, and the prostaglandin D2 and E2. Okay, the prostaglandin A2 causes vasoconstriction and increase the platelet aggregation, that is prothrombotic. The prostacyclin PGI2 platelet grouping inhibitor, platelet gathering inhibitor. Okay, I'm sorry for that. Vasodilation decrease the platelet aggregation. This is antithrombotic. You may say that they are performing exact opposite actions. Then prostaglandin D2 and prostaglandin E2, they are going to cause vasodilation and increase the vascular permeability. They are increasing the edema formation. Okay. Then we'll talk about corticosteroids. Now we'll talk about the drugs one by one. Corticosteroid, the mechanism, they inhibit the phospholipase A2 mediated conversion of the membrane phospholipids. Let me bring this picture over here. This one is a clearer picture because I need to remove a lot of the red lines from the other picture, so that is why I'm using this one. And just give me a second, it will take some time to take a screenshot, and there we go. Yep, that's good enough. Yep, so we're talking about the corticosteroids. Corticosteroids are acting over here, like they're inhibiting the phospholipase A2. Okay, so they inhibit the phospholipase A2 mediated, so they are inhibiting the phospholipase A2 mediated conversion of the membrane phospholipids to arachidonic acid, thus inhibiting both leukotrienes and prostaglandin synthesis. They freely penetrate the cell membrane. Okay, so corticoids will freely penetrate the cell membrane, binds the cytosolic glucocorticoid receptor, a type of nuclear receptor newly formed complex. Okay, so they freely penetrate the cell membrane, bind to the cytosolic glucocorticoid receptor. The receptor for the corticosteroid is present inside the cells. So that is cytosolic receptor. So cytosolic glucocorticoid receptor, a type of nuclear receptor, newly formed complex, translocates to the nucleus where it binds to the glucocorticoid response element or GRE in the promoter region of the target genes, resulting in the altered gene expression, transcription, activation, and transactivation. Okay. Then we'll talk about the side effect of glucocorticoids. Okay, so glucocorticoid mechanism of action is important, but the side effects are more important. So let's talk about the side effects. Yep, there you go. So side effect of glucocorticoids are in the skin and musculoskeletal system: central obesity, buffalo hump. Central obesity is over here, fat deposition on the abdomen and back of neck. So back of neck, if it is back on the neck, suppose this is a person standing like nose and mouth and chin, and here's the head. If there is hump on the back, something like this, okay, pardon me. If he is having a hump on the back which looks something like this, so that is a buffalo hump. Okay, so there will be buffalo hump, skin atrophy, bruisability, decrease the collagen fibroblast, decreased collagen and fibroblast, proximal muscle weakness will be there. GI tract will show peptic ulcer, GI bleeding, and decreased prostaglandins. Endocrine is showing hypothalamic pituitary axis suppression, hyperglycemia, hypogonadism, osteoporosis, decreased bone formation, and decreased calcium phosphate absorption. Immune system will show neutrophilia, that is neutrophil demargination, immunosuppression, and increased risk of infection. Nervous system will show hypomania, psychosis, and sleep disturbance. Respiratory will show increased surfactant production. Respiratory system is showing increased surfactant production. Okay, coming to this point over here, this is the effect of prolonged glucocorticoid therapy. I guess it is similar to that, but it is some more detailed version of that. Adipose tissue will show lipolysis and altered fat distribution. Adrenal cortex will show atrophy. Bone will show osteoporosis. Immune system will show suppression of the immune suppression and T cell apoptosis. Liver will show, and with the immune system, you must remember that there is an increase in the neutrophil count, that is neutrophilia, because of the neutrophil demargination, as we saw here. There is neutrophilia, neutrophil demargination, and all other cell lines will be degraded, like eosinophilic apoptosis and T cell apoptosis. All of that will be there. Only the neutrophil count will be increased because of demargination. In the liver, we find increased gluconeogenesis and glycogenesis. Skeletal muscle will show atrophy, that is glucocorticoid myopathy. Skin will show thinning, stria, and impaired wound healing. Now let's talk about the Cushing disease or syndrome symptoms. Firstly, this is a good picture, so let's see that one by one. We'll first go to the right side and then to the left side. So firstly, there will be personality changes, a red face, increased susceptibility to infection because of the decrease or suppression of the immune system. Then in the males, they can develop, which means They can develop gynecomastia, that is development of breast in the males. Then fat deposition on the abdomen and back of neck, that is called as the buffalo hump. Then the patient can develop osteoporosis, that is increased risk of fractures. Then hyperglycemia. Okay, hyperglycemia may result in personality changes or CNS problems, CNS irritability, fat round moon face, fluid retention and edema, thin extremities, GI distress and increased acid, purple stria will be present on the skin. Females will develop amenorrhea or hirsutism, thin skin and bruises and petechiae. So moving forward to the next page, just give me a second. Yep. So now let's talk about acetaminophen. It is going to reversibly inhibit the cyclooxygenase. Okay, mostly in the CNS. Acetaminophen is an NSAID, and NSAIDs are like present. Okay, other NSAIDs include acetaminophen. It is not written over here, but acetaminophen belongs to this class, and that is going to inhibit cyclooxygenase pathway, like both so COX-1 and COX-2. Clinical use is antipyretic, analgesic, but not anti-inflammatory. I guess acetaminophen is the generic name for the Panadol, which we usually use. Panadol, generic name. I think it is an NSAID. I'm not sure. Panadol. It is paracetamol. What is paracetamol? Paracetamol. Panadol. Blah blah blah. Okay, so indomethacin, not indomethacin, acetaminophen. Acetaminophen. Acetaminophen brand name, and okay, so Tylenol. Acetaminophen, Tylenol is the brand name for acetaminophen. Okay, it is very important for step 1 exam because they ask you about the acetaminophen toxicity in the liver disease, in the liver as well. Okay, so the clinical use is antipyretic and analgesic. Now we are talking about the acetaminophen, the Tylenol, used instead of aspirin to avoid the Reye's syndrome in the children with the viral infections. The adverse effects: overuse produces hepatic necrosis, the one I was talking right now. Acetaminophen metabolite NAPQI depletes the glutathione and forms toxic tissue byproducts in the liver. N-acetylcysteine is antidote and regenerates the glutathione. Overdose toxicity: mechanism normally conjugated to the sulfates and glucuronides in overdose enzymes. Mechanism normally conjugated to the sulfates and glucuronides in overdose enzymes saturated activating the oxidation pathway. Free radical produced that damage the DNA. N-acetyl P-benzoquinone (NAPQI) accumulates when the glutathione scavenger free radicals deficient, for example in alcohol consumption. Treatment is done with emesis, gastric lavage, activated charcoal, N-acetylcysteine, mucomist. Within 24 hours, neutralizes the metabolites, increase the glutathione synthesis. Now let's talk about aspirin. Aspirin is also a cyclooxygenase inhibitor, that is an irreversible inhibitor of COX-1 and COX-2 both. And said that irreversibly inhibit the cyclooxygenase both COX-1 and COX-2 by covalent acetylation, decrease the synthesis of thromboxane A2 and prostaglandins, increase the bleeding time, no effect on PT and PTT. Effect lasts only until the new platelets are produced. Okay, so effect of the aspirin lasts until the new platelets are produced, and the aspirin is going to increase the platelet time. There will be no effect on the PT and PTT. Why the platelet time is increasing? Because if we see in this picture, the production of the platelet aggregation, or if this PGI2 is inhibited, the platelet aggregation, if thromboxanes are inhibited, the platelet aggregation will be inhibited. So resultantly, the platelet time is increasing because even the platelet number remains normal, I guess. Yep. So the platelets cannot aggregate together in the presence of aspirin, and that is why the only platelet time is increased. Other values are normal. Other values are intact. Moving forward, we'll talk about the clinical use. Low dose less than 300 mg per day decrease the platelet aggregation. Intermediate dose 300 to 2400 mg per day is used as antipyretic or analgesic, and high dose 2400 to 4000 mg per day is anti-inflammatory. So you must remember these doses. That in low dose, for example, you have to give the prophylaxis to the patient who is at risk of developing that disease, like myocardial infarction, the stable plaques. Okay, he is at risk of developing the unstable plaques, so we have to give the aspirin prophylaxis. So we'll give less than 300 mg per day dosage of the aspirin. Okay, in the intermediate dose 300 to 2400 mg per day, antipyretic and analgesics can be given, and in high dose 2400 to 4000 mg per day, anti-inflammatory drugs are prescribed. Adverse effects: GIT, gastric ulceration and GIT bleeding, CNS, tinnitus of the CN7, allergic reaction especially in the patient with the asthma or nasal polyps, increased risk of bleeding, renal chronic use can lead to acute renal failure and interstitial nephritis, There is a risk of Reye syndrome in children treated with aspirin for the viral infections. Toxic doses, usually respiratory alkalosis, early due to the early but transitions to the mixed metabolic acidosis respiratory alkalosis. Okay, toxic doses, acute respiratory alkalosis early but transition to the mixed metabolic acidosis respiratory alkalosis. Okay. Then we have the celecoxib. Celecoxib is a COX-2 specific inhibitor mechanism. It reversibly and selectively inhibits the COX-2 cyclooxygenase isoform 2 or celecoxib, which is found in the inflammatory cells and vascular endothelium and mediates the inflammation and pain. Spares the COX-1, helps maintain the gastric mucosa, thus does not have corrosive effect on other NSAIDs on the GI lining. Spares the platelet function as thromboxane A2 production is dependent on COX-1. The clinical use, rheumatoid arthritis and osteoarthritis. Adverse effect, increase the risk of thrombosis in the sulfa allergy. Okay. The effect of COX inhibition on the platelet and endothelial cells. Platelets, they are acted upon by the COX-1 and the thromboxane A2 is being produced, thromboxane platelet aggregation. Okay, that will also result in vasoconstriction. In the case of endothelial cells, the COX-1 and COX-2, okay, endothelial cells produce both COX-1 and COX-2. The platelets are producing COX-1 only, and endothelial cells are producing COX-1 and COX-2 both. They will produce prostacyclins. Together they will produce prostacyclin maybe, and that inhibit the platelet aggregation. Okay, so the non-selective one, NSAID and aspirin, they will bind to both of them, while the selective one will bind only to the COX-2. So rheumatoid arthritis and osteoarthritis is the basic use of the celecoxib. Okay, so the platelets are going to cause the production of increased production of thromboxane A2, while the endothelial cells are going to increase the production of prostacyclins to inhibit the platelet aggregation. Okay, now let's move forward to the non-steroidal anti-inflammatory drugs. NSAIDs, ibuprofen, naproxen, indomethacin, ketorolac, diclofenac. Okay, acetaminophen is not an NSAID. I'm not sure about that. Okay, that's a big revelation. Acetaminophen class. Acetaminophen is a class of medication called as analgesic, pain relievers or antipyretics. It is not NSAID. Acetaminophen is not an NSAID. Remember that. Now moving forward, we have aspirin, and then okay, we're done with that. Now NSAIDs. So NSAIDs include ibuprofen, naproxen, indomethacin, and ketorolac and diclofenac, meloxicam and piroxicam. Mechanism: reversibly inhibit the cyclooxygenase, both COX-1 and COX-2, block the prostaglandin synthesis. Clinical use is antipyretic, analgesic, anti-inflammatory. Indomethacin is used to close the patent ductus arteriosus. Adverse effects include interstitial nephritis, gastric ulcer. Prostaglandins protect the gastric mucosa. Renal ischemia. Prostaglandins vasodilate the afferent arteriole. Aplastic anemia. So these are the adverse effects associated with the NSAIDs. Renal ischemia, aplastic anemia. Why renal ischemia? Because prostaglandin vasodilate the afferent arteriole. If you are giving the NSAIDs, so this vasodilation of afferent arteriole will not be there. So resultantly, we can find renal ischemia. Gastric ulcer, because the prostaglandins, PGE2, I guess, is protective for the gastric. PGE1 or E2, I'm not sure about that, but any one of both of them. So that is protective against the that is protective for what? For the gastric mucosa. And if that is gone by the NSAID, so they can be that can result in the development of gastric ulcers, and interstitial nephritis can also be seen in the chronic interstitial nephritis is associated with the chronic interstitial nephritis is associated with the chronic use of NSAIDs. For example, in the person who is having maybe rheumatoid arthritis or osteoarthritis, who is taking who has been chronically taking the NSAIDs, so he or she can develop the chronic kidney disease or the chronic interstitial nephritis. Yeah, NSAID induced gastrointestinal bleeding. COX-1 inhibition will lead to decreased thromboxane A2 production that will impair the platelet aggregation, right? And COX-1 inhibition will also decrease the PGE2 and I2 synthesis that will lead to gastric hyperacidity and impaired mucosal defenses. All of that is going to lead to the mucosal injury and bleeding. So this is the mechanism of development of the gastric ulcers and the pathogenesis of gastrointestinal bleeding in NSAID overuse. Now let's talk about what's that? Leflunomide. Leflunomide reversibly inhibits the dihydroorotate dehydrogenase, preventing the pyrimidine synthesis, suppressing the T cell proliferation. Clinical use is rheumatoid arthritis, psoriatic arthritis, Adverse effects include diarrhea, hypertension, hepatotoxicity, and teratogenicity. Then we'll talk about the bisphosphonates. Bisphosphonates include alendronate, ibendronate, risendronate, risedronate, and zoledronate. So the dronate drugs are bisphosphonates. Mechanism: they are pyrophosphate analogs. Phosphate group binds to the hydroxyapatite in the bone, inhibiting the osteoclast activity. Okay, so pyrophosphate analogs, the phosphate group binds hydroxyapatite in the bone, inhibiting the osteoclast activity. Osteoclasts that resolve the bond take up the bisphosphonate and are unable to adhere to most bony surfaces to continue resorption. So basically, the bisphosphonates are inhibitors of osteoclast activity. They will decrease the osteoclast activity. The mechanism is that the phosphate group binds to the hydroxyapatite in the bone, inhibiting the osteoclast activity. Osteoclasts that resolve the bond take up the bisphosphonates and are unable to adhere to the bond adhere to more bony surfaces to continue the resorption, induce the osteoclast apoptosis and decreasing recruitment of the osteoclast precursor cells. The net result is decreased bone loss and stable or increased bone mineral density, BMD, on the serial bone densitometry. Okay, so in serial bone densitometry. Clinical use: osteoporosis, hypercalcemia, Paget's disease of the bone, metastatic bone disease, osteogenesis imperfecta. Adverse effects are esophagitis, osteonecrosis of the jaw, and atypical femoral neck fractures, femoral stress fractures. So esophagitis, if taken orally, patients are advised to take with water and remain upright for 30 minutes. Osteonecrosis of jaw, pain and swelling in the mandible, may cause pathological fractures of the jaw and often occurs in setting of dental disease. Atypical femoral stress fracture, most hip fractures, intracapsular or trochanteric and associated with trauma. Atypical hip fractures below the lesser trochanter femoral diaphysis, no or minimal trauma. Okay, there either maybe no trauma at all or maybe minimal trauma is associated with the atypical femoral stress fracture if the person is taking the bisphosphonate. So there is a risk of development of that. Okay. Then we have triparatide. Mechanism: it is a recombinant parathyroid analog. Okay, increases the osteoblastic activity when administered in the pulsatile fashion. It will increase the osteoblastic activity when it is administered in a pulsatile fashion. Causes increased bone growth compared to the anti-responsive therapy. Anti-resorptive therapies, for example, the bisphosphonates, stimulate the maturation of osteoblasts in the bone forming osteoblasts that lay down the collagen and eventually mineralize the matrix. Clinical use is osteoporosis. Adverse effects include increased risk of osteosarcoma. Avoid use in the patient with a Paget's disease of the bone or unexplained elevation of the alkaline phosphatase. Avoid in the patients to have had prior cancer or radiation therapy. Transient hypercalcemia is an adverse effect. So there are two adverse effects: increased risk of osteosarcoma, that is the cancer, and increased risk of transient hypercalcemia can also be seen. Now let's talk about SERMs. SERMs are selective estrogen receptor modulators, or for example raloxifene. Mechanism of action: estrogen action on the bones and anti-estrogen on the breast and uterus. So it has pro-estrogen actions on the bone and anti-estrogen action on the breast and uterus, also used in the prevention of breast cancer. Okay, side effects include hot flashes, DVT, and pulmonary embolism. Moving forward, we have acute gout drugs. I guess we are done with this one. Okay, let's keep it. NSAIDs. For the gout, we can use any NSAID like the diclofenac, ketorolac, ibuprofen, naproxen, and the indomethacin, and not acetaminophen. Use salicylates with caution. May decrease uric acid excretion and particularly low doses. Salicylates. What is salicylate? For example, salicylates. Aspirin is a salicylate, right? Cyclate prototype. Salicylate prototype is salicylate. Aspirin is a prototype drug for that. Okay, so or prodrug may also say that. Okay, glucocorticoids, oral, intra-articular or parenteral. Glucocorticoid administration for the gout, like either we can give oral or we can give intra-articular, intra-joint the injections directly into the joints, or maybe parenteral route can be used. Colchicine. The mechanism: it binds and stabilizes the tubulin to inhibit the microtubule polymerization, impairing the neutrophil chemotaxis and degranulation. Colchicine is going to bind and stabilize the tubulin to inhibit the microtubule polymerization, impairing the neutrophil chemotaxis and degranulation. Also reduces the formation of leukotriene B4. The clinical use, the colchicine is an inhibitor of leukotriene B4. Colchicine is an inhibitor of leukotriene B4. Okay, so clinical use is gout, acute, and so gout for acute and prophylactic value. It can also be used in the pericarditis. Familial Mediterranean fever can also be favored by the use of colchicine. Side effects include GIT, diarrhea, and most common. Diarrhea is the most common, and neuromyopathic side effects. Chronic gout drugs, which are preventive for the gout, recommended for the patients with frequent gouty attacks, uric acid, kidney stones, and tophi, which we saw. These are like calcium deposition under the skin, and chronic joint destruction from the gut. Okay, then we have prophylactic therapy is usually initiated during the intercritical between attacks periods, or as acute changes in the serum uric acid levels can worsen an acute attack. Okay, the first line treatment to prevent the recurrent attacks is xanthine oxidase inhibitor, for example allopurinol, febuxostat, which decreases the uric acid production. Then we have allopurinol. So let's talk about that. Allopurinol, it is a competitive inhibitor of the xanthine oxidase, decreases the conversion of hypoxanthine and xanthine to urate. Okay, so here you can see that the diet in which the purines which are taken in the diet, or maybe which are formed due to the breakdown of nucleic acid, they are converted into hypoxanthine. That hypoxanthine is converted into xanthine by xanthine oxidase, and that xanthine is converted into plasma uric acid again by xanthine oxidase. If we could inhibit this xanthine oxidase, the production of uric acid can be curtailed or cut down, and that is done by allopurinol and febuxostat, right? So here you can see the plasma uric acid, if it starts accumulating, or if it is producing in a very high amount, or not being released, not being excreted, so resultant in urate crystal deposited in the joints, can result in gout. So also used in lymphoma and leukemia to prevent the tumor lysis associated urate nephropathy. Increased concentration of azathioprine and 6-mercaptopurine, both normally metabolized by the xanthine oxidase. Azathioprine is converted to 6-mercaptopurine. That says 6-mercaptopurine is going to produce HGPRT, acute metabolites, purine synthesis inhibition, and cytotoxic metabolites, and TMPT. What's that? The TMPT means thiopurine methyltransferase. So 6-mercaptopurine, if it is acted upon by thiopurine methyltransferase and xanthine oxidase, can be converted into inactive metabolites. Allopurinol will also inhibit this thing, and the azathioprine or 6-mercaptopurine will be accumulated into the toxic levels. So you must check for the patient if he or she is taking azathioprine for rheumatoid arthritis, along with, before giving her this thing like febuxostat or allopurinol. Before administering these drugs, you must check for the concomitant uptake of the azathioprine for some other condition, or for the same condition, that is rheumatoid arthritis. In that condition, or even I guess in the gouty arthritis, we can give azathioprine if we are not giving allopurinol. Then febuxostat, it is a non-competitive inhibitor of the xanthine oxidase. Again, xanthine oxidase is being inhibited. Both allopurinol and febuxostat cause abrupt change in the serum uric acid level, which may precipitate acute gout attack. What? Both allopurinol and febuxostat cause abrupt change in the serum uric acid level, which may precipitate the acute gout attack. So initiated together with NSAID and colchicine. So that is a paradoxical effect, because of some reason allopurinol and febuxostat, when they are given, both of them individually, they can, or maybe together as well, they can cause severe acute gout attack episode. So to prevent that, we must initiate them with NSAIDs and colchicine. Let's talk about probenecid. It inhibits the reabsorption of uric acid in the proximal convoluted tubule, also inhibits the secretion of penicillin, boosts the penicillin levels. It can precipitate the uric acid calculi, therefore contraindicated in the patient with a history of renal stones, and probenecid is a sulfur drug. So remember, if a person is having sulfur drug allergy, you are not supposed to give probenecid for that reason. I'm sorry. Then we have pegloticase. It is a recombinant uric acid oxidase catalyzing uric. Okay, so it is a recombinant uricase, the enzyme which catalyzes the uric acid to allantoin conversion, a more water soluble product. So if we convert the uric acid to allantoin, as maybe depicted over here, no, it's not depicted over here, but if we could convert the uric acid into allantoin, that would be more water soluble, and that can be excreted in the urine, attached to the polyethylene glycol to prolong the half-life given every 2 weeks by infusion, and decrease the immunogenicity against the drug. So here is uric acid and this is allantoin, and that is this section is mediated by the pegloticase, that is a recombinant form of the uricase. What is rasburicase? The rasburicase, also recombinant uricase, not attached to the polyethylene glycol, rapid onset of action, more immunogenic, and used in the tumor lysis syndrome. Tumor lysis syndrome occurs in the treatment of some malignancies. Rapid cell lysis increase serum level of cell count. Hyperkalemia that causes arrhythmia. Hyperphosphatemia will cause hypocalcemia, and hyperuricemia from the breakdown of purines will lead to uric acid nephropathy and acute renal failure. Now let's talk about TNF alpha inhibitors. Etanercept, infliximab, adalimumab, certolizumab, and golimumab. So etanercept, that is a decoy receptor, fusion protein or a decoy receptor for the TNF alpha plus IgG1 Fc receptors produced by the recombinant DNA. Etanercept intercepts the TNF. So basically the tumor necrosis spectrum floats freely in the circulation. So suppose that TNF alpha is like moving like this and going to its target, TNF alpha. So this is not easy to write or maneuver. So suppose this is TNF alpha molecule and it was supposed to bind to this receptor on some cell. While it was on its way, there we gave a decoy receptor which bound it on the way, that is called as etanercept, and now this thing cannot bind to the main receptor. So these are TNF alpha receptor analogs or decoy receptor for TNF alpha and IgG1 Fc receptor produced by recombinant DNA, and etanercept intercepts the TNF alpha that is used in the rheumatoid arthritis, psoriasis, and ankylosing spondylitis. Infliximab, adalimumab, certolizumab, and golimumab, they are anti-TNF alpha monoclonal antibodies. So now these antibodies are directly targeting the TNF alpha. The etanercept is just a decoy receptor, while these are targeting directly the TNF alpha. Inflammatory bowel disease, rheumatoid arthritis, ankylosing spondylitis, and psoriasis, these are going to bind to the these are going to resist. Okay, so these antibodies are used for treatment of these conditions. Adverse effect of etanercept and infliximab in general TNF alpha inhibitors have these adverse effects, which are predisposition to infection, including the reactivation of latent TB. Always screen the patient for TB before giving him etanercept, because it is TNF alpha that is maintaining the mycobacterial organism in the granuloma, that is walled off these organisms. As soon as you give the TNF alpha inhibitors, resultantly this wall is being cleaved and the bacteria come out of it. This wall is cleaved from multiple sides and the mycobacterium are released into the circulation, and the person may develop serious complications. Even miliary TB can develop. So important. Okay, just give me a second. Yep. So since TNF alpha is important in the granuloma formation and stabilization, can also lead to the drug induced lupus. Uworld point about etanercept is that it is a fusion protein linking a soluble TNF alpha receptor to the Fc component of the human immunoglobulin G1. Etanercept reduces the biological activity of TNF alpha by acting as a decoy receptor. Pharmaceutical companies provide the prefix for the name of the biological agents. The suffix indicates whether the medication is a monoclonal antibody, for example MAB, or a receptor molecule, that is sept, or kinase inhibitor, for example NIB, and if it is a chimeric antibody, it is iximab, something on those lines. For example, infliximab is a chimeric antibody, but MAB is basically for the monoclonal antibody. So remember this thing, and then there will be a very, very horrible table in the Uworld, which we'll see when it comes in the Uworld sessions. So now let's move on to the methotrexate. Methotrexate is the first line DMARD, that is disease modifying agents for the rheumatic disease. Okay, so disease modifying treatment for most patients with a moderate rheumatoid arthritis. Mechanism: folate antimetabolite that targets rapidly proliferating cells by halting the purine and pyrimidine synthesis through irreversible binding of the dihydrofolate reductase. Methotrexate preferentially inhibits the growth of rapidly dividing cells such as inflammatory and neoplastic cells. Adverse effects: its inhibitory effect on rapidly dividing cells cause toxicity to oral and gastrointestinal mucosa, that are ulcerations, hair follicles, that are alopecia, bone marrow, pancytopenia. Methotrexate can also cause hepatotoxicity, hepatic fibrosis, and cirrhosis, pulmonary fibrosis, and associated with increased risk of opportunistic infections. Disease modifying anti-rheumatic drugs or DMARDs. These are methotrexate, leflunomide, hydroxychloroquine, sulfasalazine, and TNF alpha inhibitors. We have discussed most of them with an exception of sulfasalazine and hydroxychloroquine. So methotrexate is a purine antimetabolite. Adverse effects include hepatotoxicity, stomatitis, and cytopenias. Leflunomide is a pyrimidine synthesis inhibitor. It causes hepatotoxicity and cytopenias. Hydroxychloroquine is TNF and interleukin-1 suppressor that causes retinopathy as an adverse effect. Sulfasalazine is a tumor necrosis factor and interleukin-1 suppressor. Okay, so the mechanism of action of same both the drug is same. So that causes hepatotoxicity, stomatitis, and hemolytic anemia as an adverse effect. The TNF alpha inhibitors include adalimumab, certolizumab, golimumab, and in golimumab these are humanized monoclonal antibodies. Infliximab is a chimeric monoclonal antibody, and etanercept is a decoy receptor. They can cause infection, demyelination, congestive heart failure, and malignancy. So moving to the additional points, now we're done with our MSK. Most of it, now the additional points. MSK first aid 2021 updates, skeletal muscle adaptations, myofibrils. In atrophy, they are decreased, removal by ubiquitin proteasome system, and the myonuclei, they will also decrease by selective apoptosis. In hypertrophy, the myofibrils are increased, addition of sarcomere in parallel, and the myonuclei, they will also increase because of fusion of the satellite cells. The cell biology of the bone. So we have made, okay, so this is the cell biology. The osteoclast precursor. Suppose we have bone formation, this is the osteoblast. Osteoblast has rank ligand on the surface. Now if the rank ligand is bound to the osteoprotein, so it will not allow the osteoclast to be activated. But if the rank ligand is bound by the rank on the surface of the osteoclast, so that will give a positive signal to the osteoclast precursor, and resultantly a multinucleated osteoclast is being formed that can cause the bone resorption. So that will differentiate and that will cause the bone resorption. Now let's talk about myositis ossificans. Hypertrophic, heterotopic, let's move that. Heterotopic ossification involving the skeletal muscle, for example the quadriceps, associated with a blunt muscle trauma, presents as painful soft tissue mass. Imaging shows eggshell calcification. Histology shows metaplastic bone surrounding area of fibroblast proliferation. Benign, may be mistaken for sarcoma. Dermatologic manifestations include dyskeratosis. So dyskeratosis means abnormal premature keratinization, and example is squamous cell carcinoma, that is a dyskeratosis, that is an example of dyskeratosis in which we have abnormal premature keratinization. Now we'll talk about lower extremity ulcers. So let's zoom it in. Etiology. First we will talk about venous ulcer, then arterial ulcer, then neuropathic ulcer. So let's discuss the etiology of venous ulcer. Chronic venous insufficiency, most common ulcer type. Location is gaiter area, ankle to mid calf, and typically over malleoli. Appearance irregular border and shallow exudative. Pain is mild to moderate. Associated signs are telangiectasias, varicose veins, edema, stasis dermatitis, that is erythema, erythematous, eczematous patches. So these are the findings which we find in the venous ulcer. Okay, there will be telangiectasia, then varicose veins, edema, stasis dermatitis, erythematous, eczema, eczematous patches, and location is a gaiter area, ankle to mid calf. So there is gaiter area typically over the malleoli. Okay. Then the arterial area, arterial ulcer, the etiology is peripheral artery disease, for example the atherosclerotic stenosis, which will result in the PAD. Distal toes, anterior shin, and pressure points are the site of the development of arterial ulcer. Symmetric with well-defined punched out appearance. So symmetric, what is appearance is symmetric with well-defined punched out appearance. The pain is severe. Associated signs include signs of arterial insufficiency, including the cold, pale, atrophic skin with hair loss and nail dystrophy and absent pulses. Okay, so the absence of the pulse, nail dystrophy, and loss of hair, atrophic skin with hair loss, and including cold and pale with arterial insufficiency, that is found in the case of arterial ulcers. And for the neuropathic ulcer, the etiology is peripheral neuropathy, that is diabetic foot, for example. They are found most commonly in the bony prominences, for example metatarsal heads and heels. The appearance is hyperkeratotic edge with the undermined borders. So hyperkeratotic edge with the undermined borders, this is the neuropathic ulcer, and here we can see the arterial ulcer. So the pain is absent in the case of neuropathic ulcer because the nerves are died out, and the classic picture, the signs, right? The associated signs are claw toes, Charcot joints, and absent reflexes. So these are three types of ulcers which are found in the lower extremity, which is venous, arterial, and neuropathic. Then there are Uworld updates. Common overuse injuries include traction apophysitis, and we did that. Traction apophysitis, severe disease, age 8 to 12, osteochondrosis of the heel. Osgood Schlatter's, age 11 to 15, apophysitis of the tibial tubercle. What is that? Sending Larson Johnson, age 10 to 15, apoptosis of the inferior pole of patella. Apophysitis of inferior pole of the patella and little league elbow, 10 to 15, apophysitis of the medial epicondyle of the elbow. So these are the names of different apophysites. Treatment is relative rest and strengthening. What is cricothyrotomy? Incision is done through these structures. And whenever we're doing the emergency cricothyrotomy, or the emergency sort of procedure for making the airway patent, so we are doing incision is done through these structures. First one, skin, then superficial cervical fascia, subcutaneous fat and platysma, deep cervical fascia investing and pretracheal fascia, then cricothyrotomy, cricothyroid membrane. After that we go to the facial layers of neck. So the facial layers of neck are as follows. The first one is the fascia. The first column is indicating the fascia, then location and the enclosed structure. You must look for some diagram because it is not possible to discuss these fascias without the diagram. Right now I'm just reading them, but you must look for the diagrams. Superficial cervical fascia, that lies between the skin and deep cervical fascia. Okay, that lies between the skin and deep cervical fascia. It is then closed structure platysma and subcutaneous fat. Okay, so what are the facial neck? Okay, let's see that. Facial layers of neck. I guess this picture is better. Let's bring this picture over there. And also this one. So let's take them over there to the PDF. So they are talking about the superficial cervical fascia. Where superficial cervical fascia? The superficial cervical fascia investing layer, pretracheal layer. Okay, so superficial cervical fascia is present in this picture. No, it's not present in any of them. Okay, so superficial cervical fascia lies between the skin and the deep cervical fascia. Where is deep cervical fascia? The deep cervical fascia. Okay, even this is not present over here. Lies between the skin and the deep cervical fascia. Platysma and subcutaneous fat is enclosed in that. Okay, so let's move forward. The deep cervical layer, it has following. The deep cervical fascia has following layers: investing layer, pretracheal, prevertebral, and carotid shed. So the pretracheal layer or the investing layer, even this is the layer of cervical shed. So this is a deep cervical fascia. The deep cervical fascia, all of this is deep cervical fascia, and the superficial fascia is present around that or outside this one. So in this picture, they are just referring to the deep cervical fascia. I guess this picture may be doing something good. So sternothyroid is over there, and this is pretracheal fascia. So thyroid gland. Okay, just forget about this one. This is totally useless. So deep cervical fascia, the deep cervical fascia, it has investing layer, the pretracheal layer, then it has prevertebral layer and carotid shed. The investing layer surrounds the neck like a collar, enclosing all of the deeper part of the neck. So here you can see the investing layer is surrounding the neck like a collar, and it is encasing all of the structures inside it. Sternocleidomastoid, trapezius, and strap muscle and submaxillary and parotid glands are present inside this one. The sternocleidomastoid, where is that? Sternocleidomastoid muscle. Then the trapezius muscle on behind trapezius muscle. Then we have submaxillary and parotid glands. Submaxillary and parotid glands, which are not depicted in this picture, but they are also enclosed in the investing layer of the deep cervical fascia. Got it? Then the pretracheal layer, anterior part of the neck, blends laterally with the carotid shed. So it is present on the anterior part of the neck and it blends laterally with the carotid shed. It encloses the viscera of the neck, thyroid, parathyroid, larynx, trachea, pharynx, and esophagus. So it is present on the anterior part of the neck and blends laterally with the carotid shed. So the pretracheal layer is present on the anterior aspect of the neck and it blends laterally with the carotid shed. Here you can see this part where my cursor is right now, over here. Okay, this thing is the pretracheal layer and it moves laterally to blend with the carotid shed. Got it? Encloses the viscera of the neck, thyroid, parathyroid, larynx, trachea, pharynx, and esophagus. Then the prevertebral fascia surrounds the vertebral column and muscles of the spine. So the prevertebral fascia is over here. Okay, pardon me. Let's talk about the structure which are enclosed by the pretracheal fascia first. Then close the viscera of the neck, including the thyroid. Where is okay? This purple structure is the thyroid, right? The purple structure is thyroid. Then we have parathyroid glands, okay, which will be present behind that, and they're also enclosed inside the pretracheal fascia. Then larynx, okay, they're not the gut section is below larynx. Then trachea, as you can see over here, trachea. Then pharynx and esophagus. The pharynx and esophagus are also present in the investing layer. So this is a reflection of the investing layer which is enclosing the trachea and esophagus as well. The prevertebral fascia surrounds the vertebral column and the muscle of the spine. Vertebral column and the muscle of spine are surrounded by the prevertebral fascia. So here the prevertebral fascia. Okay. So this thing, the prevertebral fascia is encasing the vertebral column and the muscle associated with that. Surround the vertebral column and the muscle of the spine. Vertebral column, scalene, longus colli, splenius, erectospinalis, semispinalis, and the levator scapular muscles are all enclosed in the prevertebral fascia. The carotid sheath, it lies lateral to the retropharyngeal space, deep to the sternocleidomastoid muscle. Carotid sheath, it lies lateral to the retropharyngeal spaces. Okay, retropharyngeal space, where is that? I don't know, but this is the carotid sheath over here. So the lies related to the retropharyngeal spaces deep to the sternocleidomastoid muscle. The sternocleidomastoid muscle is over here, and the carotid sheath is lying deep to that. It is enclosing the carotid artery, internal jugular vein, and the vagus nerve. If you could see over here, so this is carotid artery, internal jugular vein, and the vagus nerve is present inside the carotid sheath. And this is all of them are the layers of deep cervical fascia. Let's take a picture of superficial cervical fascia and superficial cervical fascia. This is superficial cervical fascia in this picture. You can see the yellow one is a superficial cervical fascia which is surrounding these deep structures, and then we'll go to all of them. Okay, where we? So these are the neck fascia. Then you must remember them because they are pretty high yield. And acetylcholine, substance P, serotonin, bradykinin, they will act on the endothelial receptor, increase the calcium. Arginine plus oxygen will lead to the formation of citrulline plus nitrous oxide, nitric oxide. It is not NO2, it is NO basically. So it is nitric oxide production. Dimethyl arginine is an endogenous analog of arginine that decreases the nitric oxide synthetase. Okay, so if we give dimethyl arginine, that is an endogenous analog of the arginine and that decreases the activity of nitric oxide synthetase. Type of muscle fibers, don't be confused. What's that? Okay, so type 1A for sustained postural muscle, for example the paraspinal muscles. Type 2A, that is intermediate between type 1 and type 2B, use aerobic glycolysis, and type 2B use aerobic glycolysis. Okay, type 2A are intermediate between type 1 and type 2B, so they use aerobic glycolysis, and type 2B also use aerobic glycolysis. Types of bone. Trabecular bone compose only 15% of the skeleton, metabolically more active. In initial phases of osteoporosis, trabecular thinning and perforation with the loss of interconnecting bridges. Cortical bone affected in the advanced osteoporosis. Why rheumatoid arthritis have greater or have higher risk of neurologic manifestations and complications? The answer is rheumatoid arthritis usually involves the cervical spine and atlantoaxial joint that leads to joint destruction, atlantoaxial subluxation. As C1 has higher mobility relative to C2. Okay, so why rheumatoid arthritis have high risk of neurologic manifestations and complications? Rheumatoid arthritis usually involves cervical spine and atlantoaxial joint that leads to joint destruction at the atlantoaxial subluxation. As the C1 has higher mobility relative to the C2, chronic symptoms, neck pain, stiffness, and neurologic findings. Endotracheal intubation acutely worsen the subluxation and cause compression of the spinal cord that will result in the spinal shock. Difference between the gout and pseudo gout in the pattern of joint affection, okay, or the pattern of joint involvement. Pseudo gout, more than 50% of the cases in knees involved, and in the gout more commonly affect the first metatarsophalangeal joint. Difference of the osteomyelitis in adults and children. In children, the site of infection is metaphysis of the long bone, slow flow sinusoidal vasculature. In adults, the vertebral body is most common location in the adults. Characters of the hypothyroid myopathy associated with the sign of hypothyroidism: proximal muscle weakness, myoedema, focal muscle contraction at the site of percussion due to decreased uptake of calcium from the sarcoplasmic reticulum, okay, and hung up reflexes, delayed relaxation phase of the deep tendon reflexes. Type of exocrine glands, they can be merocrine, apocrine, or holocrine. We have seen this table before. Merocrine is the one in which the cells secrete by exocytosis. They include salivary glands, the acrine sweat glands, and the apocrine sweat glands. The apocrine glands, cells secrete by the membrane bound vesicles, for example the mammary glands, and holocrine, cell lysis release the entire contents of the cytoplasm and cell membrane, for example the sebaceous glands and the meibomian glands. Then we'll talk about what's that? Aphylitis and Aphelides and acrocoda. Okay, Aphelides freckles, solar lentiginous freckles increase melanin production. Okay, freckles are formed on the arms because of increased melanin production, and lentiginous increased melanocytes larger in adults. Epi, okay, I can't even pronounce that. Aphelides. Okay, aphelides or freckles. We have seen that. We have studied a complete detail about that. It is called as aphelides. What is acrocoda? For skin tags like this one. So location of most friction, for example, axilla, they may develop skin tags, that is acrocoda, while the aphelides or freckles, it is increase in the melanin production. The number of melanocytes is just the same, but the melanin production of the melanosomes are increased. Okay, and lentiginous is increased melanocytes rather than larger in adults. Okay, so lentiginous is a condition in which the melanocyte number is increasing. The freckles have increased number of melanosomes, while the lentiginous have increased number of melanocytes. So remember the difference. Now let's move to the next page and we are done. Oh, thank God we are done. Alhamdulillah. So we are done with the MSK and we'll see you in the next session. Until then, Allah Hafiz, fi amanillah, and take